Okay. Hi, everyone, and thank you so much for sharing your Sunday morning with us for the third in our series of four sub-I panels, this time focused on navigating the operating room. My name is Zachariah Samuel, and I'm an M3 at the CUNY School of Medicine, and I'm joined by Emily Mateys, an M3 at Michigan State University College of Osteopathic Medicine, and so we'll be co-moderating this panel, and we're very excited to be here. We have an extraordinary set of five panelists here with us today. Emily will be introducing them to all of you guys in a moment, but first I wanted to outline the plan for this morning briefly. As mentioned, we'll be discussing navigating the operating room. We'll be hearing from our panelists about how to prepare for cases, what proper OR etiquette looks like, how to best contribute to the team as a medical student, and more. So once again, thank you all for joining us. And with that, I'll pass it over to Emily for introductions.
Hi, everyone. Here are our five distinguished panelists. First, we have Dr. Sean Tabai, who serves as the medical director of the Sports Performance and Motion Analysis Lab at Children's National. Dr. Tabai earned his MD from the Chicago Medical School, and he then completed his residency at St. Louis University Hospital, followed by an advanced fellowship in pediatric orthopedic surgery at the Northern California Shriners Hospital for Children and UC Davis Medical Center, as well as a second fellowship at the Royal Children's Hospital for treatment of children with complex limb deformities and cerebral palsy. Then we have Dr. Diana Silas, who serves as a sports medicine specialist with a focus on joint preservation and advanced hip arthroscopy at Motor City Orthopedics in Michigan. Dr. Silas completed medical school at Michigan State College of Osteopathic Medicine, followed by residency at McLaren Oakland, and a fellowship in sports medicine at the University of Rochester with a focus on joint preservation and shoulder arthroplasty. She's active within the American Osteopathic Academy of Orthopedics and has lectured nationally and internationally on topics ranging from hip, knee, and shoulder preservation to shoulder replacement. Hassan Farouk is a PGY2 at Loyola, who also serves as a resident advisor for MSOS. He completed undergrad at Indiana University in Northwest and attended Indiana University for medical school. Garrett Berger is currently a PGY3 at the University of California, San Diego. Originally from Tucson, Arizona, he attended the University of Arizona for undergrad and the Medical College of Wisconsin for medical school. Hassan Destine is a M4 from the University of Miami's Miller School of Medicine, and he completed a research fellowship at the Rothman Orthopedic Institute. Additionally, he serves as the co-founder of the Ortho Plug, a place for resources, tips, and inspiration for underrepresented minority students interested in orthopedic surgery. Henson recently matched at the University of Pittsburgh Medical Center. Thank you to all of our panelists for volunteering their time to share their advice with us today. And with that said, let's get into the questions. Each question will be addressed to two panelists, but all panelists are welcome to jump in at any time. So our first question is for Hassan and Henson. What steps can medical students take to prepare themselves before entering the OR at a new institution? And we'll go ahead and start with Hassan.
Yeah, that can be a daunting task when you're starting at a place that you're not familiar with, not even like logistically. So I think stuff you can do to kind of prepare yourself for that first day in OR at a new place or an away rotation is, reaching out before you're there, potentially a couple days before, and see if there's anybody that can kind of take you around the hospital, if there's someone on call that day or the weekend, some sort of communication prior to just kind of logistically map out the place so that on your first day you have some sort of semblance of what to do and where to go. I always think that's like very helpful that way. There's already so many factors that are unknown when you're going to a new place that takes one of them into your control. So I think that's one thing you can do. I think secondarily is figuring out the cases the day before. So whatever cases are going to be happening, I think it's helpful to, find that out the night before. So again, it's all about preparation, right? So that preparation leads to comfortability, leads you to be more prepared, it leads you to perform much better. So I think figuring out from whether that be your resident contact or wherever that may be at a program, figure out what cases are going to be going on so that you have ample time to at least prepare and read from them. I'll pass it over to Henson to kind of chime since it seems like he just recently did some aways here.
Yeah, similar to what Hassan said, finding the ER is definitely probably going to be the biggest thing. The first day is always weird because you'll most likely have orientation that first day. And so you're not going to be starting at like the typical time for most people at almost all your institutions. So finding the OR, it's not like you're gonna have, most of the time you won't have a resident to take you. Someone will probably drop you off. So if you know where the OR is, that's gonna be helpful. The day before, or even like the day before, even like that morning, finding out where to get scrubbed is gonna be huge. Asking maybe like the person at the front desk, like, okay, like, is in this, or do we need like boot covers? Do we need beer covers? Just because every institution is gonna have different policies. Like, I know at some places it didn't really need it. At other places they were stringent on it. So finding those things out before you scrub in is gonna be probably gonna save you a lot of time, and also like a lot of disruptions to the normal flow and day of everything. And then also just like realizing like what Hassan said, knowing the cases, what's probably going to be in the case. Maybe like how many, like if there's going to be equipment, if it's like if it's an arthroplasty case or a arthroscopy case, and then that could also like kind of dictate where you stand. But the biggest thing is knowing like how will you be able to integrate into this space without necessarily disrupting things.
Yeah, and thank you guys for those tips on kind of preparing before you even start. And more along those lines, uh, we wanted to ask specifically to Dr. Tabai and Garrett if there are any specific surgical skills that you'd recommend medical students to familiarize themselves with, such as specific suturing techniques, knot tying, or any kind of medical equipment use. Dr. Tabai, you could start.
Yeah, that's a great question. So similar to what everyone's been touching on this whole day, we don't expect medical students to come in and be experts in our different procedures, but having some understanding is great. So in regards to suturing, I never expect a medical student to be able to suture right off the bat. If they understand the different types of sutures we utilize, like if it's a subcuticular, if it's a horizontal mattress, vertical mattress, that's great. And sometimes I do ask that. And that's usually the first step. I mean, an understanding of that before we hand them over suture and have them start practicing. So understanding the different types of sutures is great, and maybe even going through it with the resident ahead of time, because the residents usually relay to us like, okay, this student has shown some affinity towards doing this and wanting to do this. And so I think that's key. As far as equipment, I really recommend everyone early on just to get their hands on a drill. Just hold things, just being able to like kind of manipulate a drill, hold a drill with both hands, maybe drill with a wire driver to hold a wire, and realizing just the feel of that, because you'd be surprised even for early residents, sometimes they don't have enough experience with that. And that's really easy to do at home. You can just buy any over-the-counter drill and just play with it so that you have some familiarity there. Other than that, really, it's not about the skills in the OR to have, it's just about the awareness and how to kind of navigate yourself within that OR space that I'm sure we'll touch on.
Yeah, I think echo some of those sentiments with respect to not expecting you to show up and be a finished product. Like I start my foot and ankle rotation in a couple of weeks. I'm not going to be expected to perform a perfect total ankle on my first day. The point is that you are learning as you progress through the rotation. I think medical students rotating are no different. So with respect to the suturing, I think you hit on that. A lot of this is service dependent. So if you're going to be rotating on trauma, probably more nylon or staples or whatever is used at your institution, versus sports, it's going to be more the portal sutures. Joints may do some running subcuticular stuff. I think with respect to equipment, totally agree about the drill. I think like doing an IKEA project could be your best friend as you want to practice for your rotation. But another piece of equipment that I think is not thought about as often, like with sports, are the knee braces, right? I think they can be a little bit finicky out of the package. And if you just pay attention to how your resident manages that through the first couple of cases, they kind of unlock it and fit it to what they think is going to be needed for the patient. They might trim the straps so they're not wrapping all the way around and make them more efficient. And then as you progress to that rotation, you can start to be, hey, here's the scissors to trim it. And then the next case, you're trimming it, right? So just showing the ability to pay attention to what's going on and then become useful in the things that you are capable of doing. You're probably not going to be the one scoping the knee, but you can make yourself useful and show that you're paying attention and show that you have the ability to learn, because ultimately that's what you're going to be as a resident, is an unfinished product that needs to be able to learn into an autonomous surgeon at the end. So focus less on trying to be perfect coming in and more on paying very close attention on how you can be helpful with the things going on around you.
Yeah. No, just to touch on what Garrett said, that was great. And I think it's about the progression, right? Usually you'll spend a couple weeks on each service and you'll probably be with a specific attending in the OR more than once. I like to see when there is a progression. Like when I introduce something to a student or a resident, and then the next time around, they definitely like taking note of that. So I would, as Dr. Ward was mentioning in the previous session, take a journal, write down every case, write down what you used. So when you come back in that room, you've shown that you've taken that next step up. And then lastly, again, everything kind of works together. When you're taking call, you're putting on splints and casts, and often post-op in the OR, we're putting on splints or casts, especially in my world, pediatrics. So if you've done that, that's a great skill to have, to jump in and help put on a splint or a cast. That's will always impress us.
Thank you both. Those were great tips. I love the journal suggestion and getting with residents kind of to work on suturing. I think that's great. And everyone, let's get to IKEA. And our next question is going to be towards Hassan and Henson. What resources did you find most helpful when studying for cases? And what's the best way to use these resources?
In my opinion, like I think Ortho Bullets is obviously like a cursory kind of good overall review. It's easy to read. I always kind of went to that first just to kind of even learn about a certain injury or a certain surgery. I think kind of reviewing that is also efficient for like someone that's on a rotation that might be very busy. So I definitely started there, kind of start broad and then kind of work in. But the kind of workhorse for like preparing for the OR for me was Surgical Exposures by Hoppenfeld. It's a textbook that goes over, you know, in a really nice way with regional anatomy, really focused each of these approaches to different parts of the extremities. So for me, it was always kind of start with Ortho Bullets, learn a little bit about a certain injury first, see what's kind of highlighted there as important, then go to the Hoppenfeld's book and learn that approach best as I can. And then there's always, I think, for more information, the Netter's Concise Orthopedic Anatomy book. I think those three-prong approach can kind of effectively set you up to do well in the OR. As a med student, most of your questions are, the expectation is your regional anatomy, and that's the main kind of expectation from the attendings. So I think if you do that, you're setting yourself up to look really good in the OR and be successful.
For me, similar to what he said, pretty much the same resources. I developed like just like a three-step thing that I always did for almost all of my cases. I always started with Netters just to learn the anatomy of like the region where you're going to be. You're on a service, so just read the Netters for everything involved within that service. And then if you want to keep refreshing it, you could do the Anki. I'm not much of an Anki person, so I just kept reading Netters before every case. And if you know the exact case, you could just focus on that specific body part. Second, I always read Hoppenfeld's. It's a pretty thick book and it's a lot, but I think it was probably the most useful for anything, just because one, you're gonna know where you are and what you're doing, and two, you're gonna know anything relevant, because Hoppenfeld's, like Hassan said, it does go into like the levels where you're gonna be operating, the important structures that are there. And then the third thing I did was I went through Pocket Pimped. And you just cram as many of those questions as you can. If you have time, you could, I guess, do the Yankee for it also. But for me, it was just like read over and over again until hopefully I remember as much of it as possible. So that was like my tried and true three-step thing, just anatomy, what's going on, and then potential questions that might be asked. And then if I had some more time, you could do other things. Like I guess you could go on YouTube and kind of look at things on that way. You could do Ortho Bullets, which I did once or twice. And on trauma, there's another app. Let me check my phone. I think I still have it. There's another app I use on trauma, AO surgery reference, which was really nice just because trauma you can't predict. So like right before the case, while you're still waiting for people to roll, things to happen, patient to go to sleep, just look through AO and figure out like, okay, this is what's happening here just because you didn't have time. And Hoppenfeld is a PDF, so I had it downloaded. And I had the tab always open on my phone. So I would do AO, and if I still had like 5 or so minutes, I'd go to Hoppenfeld's and then skip straight to where it said like the layers where you're gonna be working on, because that was pretty much something where I'm like, okay, this will probably 100% be needed.
Awesome. Yeah, thank you guys for sharing those resources. I think those will be really helpful for students. This next question is going to go to Garrett and Dr. Silas, and it's just going to be asking how a medical student can effectively contribute to the team before a procedure. So, Garrett, you can start.
Sure. I think here, this is probably institution dependent for sure, but getting to the OR early, you'll probably hear the term burn dogging a lot, but that's essentially just letting your resident know when the patient's in the room while your resident's completing whatever task they have to do, lots of documentation and arduous things that go on throughout the day that are not surgery. So getting there early, letting them know when the patient's in the room, but there are a lot of things you can do during that time. So getting the computer booted up and the imaging software going with whatever relevant imaging is needed for that case pulled up, I think that's super helpful. Writing your name on the whiteboard along with the resident's name or whoever needs to be on there, just making sure that everyone in the OR, the scrub, and the circulator know who you are, pulling your own gown and gloves, things like that. You can also pre-scrub, which I'm sure is something you've been doing as MS3s, just to make sure that you're as prepared as you can be so that you are not the one slowing down the case when the time comes. So you're able to scrub in and be out of the way and ready to help as needed. But otherwise, I think just everything that's been mentioned as far as preparing for the case is going to be the best value for your time.
Yeah, that's great, Garrett. I mean, because in my mind, contributing to the team is truly being nice to the nurse, getting to know the nurse, getting to know all the ancillary team members is probably one of the best things that you can do. Sometimes when I walk into a room, I'm meeting a medical student for the first time. When the patient is asleep on the table, don't introduce yourself to me as going to be in the room, because that does sometimes you lose sight of, gosh, I'm a patient laying here and the team doesn't even know each other. It almost can make a patient nervous, right? So just remember that there is a person on the table. Even if you're just meeting the surgeon who's going to be in the room for the first time, if the resident knows they're there, because sometimes how things work is you find out you have a medical student as you're walking in the room, and that's okay. But I will also say sometimes some of the best introductions happen naturally. So if you're there, you're present, you do all the things that Garrett said to do. If you see that there's an x-ray boom, making sure there's lead and thyroid shield so everybody in the room can be protected, even as much as asking the nurse anesthetist or anesthesiologist in the room, hey, this is an x-ray case, do you need lead? The nicer you are to everybody else, the better everybody, the more everybody will like you. And that's really what it's all about. Because if you have to think about somebody who's taking you into their program, they want to make sure that you're a nice person that they can work with for 5 years. I mean, really, at the end of the day, that's something that probably has more value. I'm sure every single person on this call is ambitious and smart. Otherwise, you wouldn't even be here. So kind of thinking outside of the box, being nice, being present, and just kind of being around, all of the skills, as everybody has so nicely mentioned, will come. But being aware of the case, introducing yourself to the team, and being aware that there's a patient who's about to have surgery are probably the best things that you can do. And also like being prepared for the case, sometimes don't ask questions just to ask a question that you could potentially ortho bullet or Google, because it doesn't really make you look better if you ask a question that you could easily find the answer to.
Totally agree. It's a hard balance. Like you want to ask questions to look interested, but don't ask very obvious things that you can look up. That doesn't show curiosity. It's you have to be an independent learner as well.
Great tips. Thank you both. I think a good lesson is to be nice in the OR and outside of the OR. The next question is for Dr. Tobai and Dr. Silas. What are the most common mistakes you see medical students make in the OR, and how could these be avoided? And we'll start with Dr. Tobai for that.
Yeah, I mean, I think Dr. Silas hit on these already, the biggest mistake is medical students coming in and not introducing themselves to the team. Introducing themselves to the surgeon is key because, again, once the patient's on the bed asleep, our mind is focused on the surgery, and to meet a student out of the blue for the first time, especially one that's here to really kind of as an audition, is, I would say, is a deterrent to their kind of success. Also, the team within the OR, the nursing tech, the scrub tech, I mean, that's the team that we work with on a daily basis and the people that we trust the most. So their impression and perception of students goes a long way. So, and they're their students' best resource. If they really like you, as a student, they often come to us and say, I really like this person, and they go to bat for them. So coming in early, introducing themselves to everyone, writing their name on the board. So things like that, if it's not done, easy things are the most common mistakes. Other things that I think are just awareness, understanding. The biggest mistakes I see with students is when they don't kind of read the room correctly. Things can be stressful, especially if they're doing like a trauma case or a more complex case. So having spatial or just situational awareness and knowing when to ask a question, when to help, when to interact, I think is key. But yeah, ultimately it just comes to the common sense things. Just biggest issues I've seen is when students are not nice, when they don't treat people with respect. It's not really skills wise. And then the last is if you're truly unprepared. Like I said before, I'm not expecting anyone to come in and take the knife or start suturing, but I do expect you to have some awareness and some understanding of what we're doing. If you come into a knee arthroscopy case and you have no idea what if there's an ACL tear versus like the basic stuff, then that is a huge issue.
Yeah, I mean, I definitely agree with all of that. And using all your resources, I mean, getting to know the schedulers, getting to know the front desk people, it really comes down to that, because the ancillary team can be a better resource than the surgeon themselves, because the ancillary team will help you figure out cases. And I will promise you there's some scrub techs where if they don't like someone, they really let us know that they don't want that person in our program, because scrub techs even look at people as, I'm going to be with this person for 5 years. And if they're arrogant as a medical student, they're going to be a rough resident to work with. So the ancillary team means so much, so much. And you may not even realize how good of friends maybe I am with my scrub tech when you're in the room. So act like everybody's best friend, everybody's friends with everybody, and you're there to impress everybody. And really, that's what it is. That's your moment of, hey, I'm normal. I can work with you. We can hang out for 5 years. We'll have a good time together. Plus, I'm interested in learning and I'm smart, which all of you are.
Yeah, that's so true. And I think another common mistake is medical students, sometimes they don't take advantage of the experience they have or their opportunity in that OR. I mean, you guys are dedicating a lot of time, resources to be there. So don't let that opportunity pass. Like when you're there, immerse yourself in what we're doing. And like, it's hard. Trust me, I was there. It's hard to speak up. You feel awkward. You don't know people. And you're just nervous about putting on a good impression, but just speak up. Like, don't stay silent, no matter how hard it is. Talk to us, engage us, because 4 weeks will fly by for a rotation, and then when you look back, you don't want to have any regret after the fact.
The other thing a scrub tech can do, because I know I find myself in a situation where if there's a medical student in the room, I tend to ask the same like 1 or 2 questions. Ask the scrub tech, say, hey, is there a question? She asks everybody. They'll be more on, they'll respect that more than hey, is there a PIM question? She asks everybody, or PAs. You'd be surprised how much information you can get out from the team.
Awesome. Yeah. Thank you guys so much for, offering your perspective on some of those softer skills. And kind of from the resident perspective, wanted to hear from Garrett and Hassan. If you guys can share your thoughts for do's and don'ts for med students in the OR, and if there are any kind of specific examples you can provide kind of from your experience of what you guys have seen. And yeah, Gary, you can start.
Sure. I've got a few, some that I wish I didn't have to mention, but I will. But I think one, we kind of hinted at the asking questions earlier. So asking good, thoughtful questions for sure. And then on top of that, asking them at appropriate times. So it might take you a little bit of time of learning to when that is, but there are difficult portions of the case, and that might not be the best time to ask this question you've been saving up the whole time. So I would say like exposure and closure are great times for asking questions. For me, just some, you asked for specific examples. I've had, believe it or not, multiple medical students like reach over and manipulate the instrument that I'm using. Like I'm reaming and then they try to push on the back of the drill to help me out. Or I was sending down a tibial nail and, lining up the rotation, and they felt that they had a better look at it. So they're reaching on top of my hand and moving my hand. Don't touch an instrument that's not in your hand. I'm just going to say that now. I don't think I should have to say that, but I'm going to. But otherwise, I think the big ones that can really hurt you at a program are what were just being discussed with respect for the OR staff, respect for the circulating nurses, the scrub techs, the custodial staff who's cleaning between cases. I mean, I really think that you need to be very respectful and cordial with these people because, as was mentioned, if you're not that as a medical student, and then once you get a little bit of title behind your name as a resident, it is the assumption that behavior will worsen. So truly be respectful of everyone there because they do this every day and you're just getting started.
Yeah, I don't have much more to add. We've talked about a lot of, good examples. I would just rehash that. Be present, and, I don't think there's a task that, especially once you're more comfortable and you've been in that OR for a few times, I don't think there should be a task that you should, think that is below you. I think that could go from, cleaning, mopping the floors, changing the bed sheets, be involved and, take ownership of those things if you feel comfortable doing them, and just be helpful. And that goes beyond just being helpful to the orthopedic team. I think there's a whole other set of team members in the room from the anesthesia side. So if you can help them while you're in there, not doing anything, I think just be as helpful as you can. I don't think there should be a task that you should think is below you, you're below you at all. And then just don't ever be mean, no matter who it is. I think if you just walk into the hospital and tell yourself that you're just going to be a nice individual, I think that takes you a long way. As simple as it sounds, it's just being nice, polite, and respectful can take you so far in this world.
Yeah, thanks, guys. Those are awesome. Our next question is for Garrett and Henson. How do you suggest medical students seek feedback on their OR skills and incorporate it into their learning during a sub-I? And we'll go ahead and start with Garrett.
Sure. I think this is hard. I think specifically from residents, we're medical students very recently, and so giving formal feedback is certainly not something that I've been taught as a resident. Like, hey, here's how you give formal feedback. That's not a thing. So it's a self-learned skill, and I think does require some initiative from a medical student. And I think it's even harder to give negative feedback. That's not something that we really want to do. But I would say starting a rotation, establishing who your point of contact is going to be, and whether it's the chief on your service or if you're paired with a junior that you're going to be with a lot, saying, hey, I'm very interested in obviously this program, but also my progression as a medical student and getting better and being more helpful. So can you just pay attention to what I'm doing over this next week and a half? And can we check in like halfway through the rotation or a third of the way through the rotation? And I would have that same discussion with whoever your faculty like advisor is for that rotation, who many of you may end up asking for a letter of recommendation. And I think that's a good time to establish that you are going to be looking for a letter of recommendation and asking them to kind of pay attention to you informally or indirectly, I should say, so that when the time comes, they can say so-and-so showed improvement in X, Y, and Z areas, was very helpful in X, Y, and Z areas, and they're just keeping their eye on you for that reason. So I think the biggest thing you can do is just early in the rotation, setting a precedent that you are going to be asking for feedback in the future.
Yeah, similar to that, I think there are, I guess, a few time periods in which you can probably preliminary ask for some feedback before going to the big guns. So first and foremost, as the case is wrapping up, usually the attending leaves, and it's probably you and the junior who's gonna be suturing or closing, and then the ancillary staff that's around. So first and foremost, you could just like, if you feel like something went wrong, or maybe you just have some questions because you haven't worked with the attending, you could ask the junior for advice. If you've been cool with them and it's not your first time, and the most of like almost 100% of the time, they're more than willing to talk to you about like, okay, different things you should pay attention to or how to better work with the attending. And then usually when all of that's over, they'll go to start writing notes or start preparing for the next case or like on a computer in the same room. And then you'll probably, be left to help like move the patient, stuff like that. You can't even ask the ancillary staff because 90% of the time they've worked with the surgeon or attending for a long time. They know like their mannerisms, they know the little things they like. They also know and have seen a ton of medical students. So they can tell you like, okay, this is what I have seen medical students do that they really like, or no, like they responded really well. So you're actually doing well, whether you know it or not. So you can get a lot of information from the ancillary staff in the room because they have been there a long time. They've seen the goods and they've seen the bads and can also tell you. And then as well as just like talking to the junior after the case. And once you feel more comfortable, then you can probably talk to the junior about how to best approach the attending, and I've had a junior like randomly like get like literally just leave just so I could talk to the attending. So I think you can start with like the lower people he'll probably be more comfortable with and then kind of work your way up from there.
Thank you so much. The next question we have is for Dr. Tabai and Garrett. What actions and qualities make a medical student stand out in the OR?
I mean, a lot of it we've already touched on, right? Is one, being prepared is key. Prepared in the fact that you walk in and you know what case we're doing, you have definitely an understanding of the basic anatomy. So I asked earlier about how do I know what approach the surgeon is going to use? And that is a good question because sometimes you don't know what case you're going to be in until hopefully the night before at the latest, but maybe even that day. So one is trying to talk to your seniors from resident standpoint when you're on a rotation, trying to get your schedule early so you can be prepared. If you can look through previous patient notes, like surgical op notes, and say, okay, I'm doing that approach to the hip, and you're like, okay, I looked at one of Dr. Tabai's previous surgeries, and you went through it. I mean, I've seen people do that, and that always impresses me greatly because it just shows that they took some initiative. And my thing with students and residents is always like, if you fail to plan, then plan on failing. So I love when people plan. It stands out. And other things that impress me is the students that, again, like I touched on, have that situational awareness, and are polite, and can hold a conversation. That's basic stuff, right? But it all goes back to we want to be around for 5 years, and we want to be around good people that we can get along.
Yeah, I totally agree. And I think for me, it's just being able to do simple things without being asked. So there's obviously no light in the wound, adjusting the lights. Someone, especially if you're on a repetitive service like joints, and you know that a certain retractor is going in at a certain time, you can just have your hand ready to hold it because you know what that next step is. Suturing at the end of the case, when they're sutured, there's going to be scissor. So getting those scissors in your hand, like doing those things without being asked to do so. Rangeur comes out, getting a lap in your hand, all that kind of stuff. If we ask you once, that's going to happen, but it's just not having to be asked to do something every single time that it needs to be done. Just showing, as the theme this whole time has been, showing the ability to learn and progress. And so if you're able to do that, I think it's noticed.
Yeah, thank you guys. And along those lines of kind of demonstrating interest, our next question is going to go to Dr. Silas and Garrett, and just asking how med students can demonstrate their interest and engagement in the OR without kind of overstepping any kind of boundaries. So Dr. Silas can start.
Yeah. So, one thing that I find kind of funny as I'm sitting here talking is I've never met Garrett. I've never met Dr. Tabai. And everybody has the same theme. So as you guys can see, there's very baseline themes that will work across the country, across hospitals, across programs. And how you can show interest without overstepping is honestly asking those questions about when do I scrub in? That's an appropriate question. If a resident or a medical student walked up to me and said, "Hey, I don't want to get in the way. When should I scrub in?" I'd be like, they have the general awareness that this is where they're supposed to be. And it's honestly being scrubbed in, not standing with your arms crossed and your hands underneath your armpits, because that's, kind of substerile. Standing with your hands on the, blue sterile field, whether it's on the body, on the back table. Honestly, just being prepared is by knowing everybody in the room. And I can't stress that enough. Being nice, being present, being clean. If you're up all night, shower, because surgery is everybody's in very close contact. We're going to be very close to you, making sure you have good hygiene, deodorant, because surgery, we're all very close. And there's nothing worse than standing somewhere for 2 hours next to somebody who did not shower the night before. So basic. And I know some of you may laugh, but we wouldn't say this stuff if it didn't happen to us.
Yeah, I don't know how much I can add to that. It's really the whole theme has been showing interest by asking pertinent questions, say that there are multiple different approaches used for a surgery. Why are you using this one, for example? I read that this could be an advantage, but what about this? I think not simple Google things, but things that require a little bit of a higher level thought, asking questions on those things. But as far as impressing us, it really is guessing the next step within reason. Obviously, we're not expecting you to be able to do the surgery, just guessing that you're going to need scissors for the next step, or guessing that you are going to be holding a retractor, and then not being super in the way. Standing out of the way is always much appreciated. And then, as Dr. Silas said, I think that's a very astute point, that you asking questions about logistics in the OR actually does show a certain level of aptitude for what's going on. Maybe in certain more formal programs, it's very structured that the attending scrubs in first, for example. I'm at UCSD. That's not the case here, and I've never seen that, but I think being aware that could be a thing and asking the question, "Hey, when should I scrub in?" is really, really beneficial for you.
Great, thank you both. Our next question is for Hassan and Henson. How can a medical student most effectively contribute to the team after a case is finished? So what can med students do once the case is over? And Hassan, can you go ahead and start with that?
I think understanding that just because the operation and the case is over doesn't mean the care of the patient is over necessarily. So I think being available to assist with getting the patient off the operating room bed to the cart itself, being available to help turn over the room, being able to help the resident who may be putting in orders, make sure that they don't need anything from you. I think just being available is like the common saying for me is the best ability is availability. So I think the more that you're just present and able to lend a hand, I think that's kind of the best way to do it. So just don't leave the room just because the case is over. Help be the last one out of that room, first one in that room. Those are kind of tips I would give people.
So when it comes to the after the case, I would say that the best thing you can do, and when it really matters, is the ending portion. Like when it comes to not only when the junior, starting from when the junior is suturing, is having your scissors to cut to help them out, helping to clean the patient afterwards, helping to move the patient, getting the bed, and all the things that Hassan said. That is when you can be the most helpful, walking the patient back to post-op. If there is a post-op, I know some institutions you don't really need to because the ancillary staff will, but others you can. And then heading straight to the next case to kind of not only bird dog, but just text the junior okay, they're ready for this or they're doing that. And based on the case, little things like that. There are some institutions where you can kind of help out with just like cleaning some things, like maybe like stripping the bed, getting like handles off, other things like that to help the ancillary staff that can also be really useful. Others you don't particularly have to. You kind of have to see how the flow of what you're doing, how like the flow is going, and then see where you can insert yourself, right? Like if it's a task where you're like, okay, I could do this so that the resident can go do something else or XYZ, then just kind of do it in that regards. And it's probably like the safest way to go about things. So the first one time or two times maybe kind of glance at just like what's going on, like what are all the little things that are happening, and then from there just um try to be proactive and the little things. Don't try to do like a major thing that you probably will mess up, but like the little things where you're like, okay, I can do this, offer to do it, and it goes a long way.
Thank you guys. And as we're having our last question for this panel, if you can give one piece of advice to medical students as they prepare specifically for the operating room on their OAs, what would it be? So everyone can answer. We can start with Dr. Silas, then go to Henson, Hassan, Garrett, and Dr. Tabai.
Probably the biggest tip that I could give is to be nice and be on time and be present. It's all very basics. It's probably goes a longer ways than you'd believe. That's
Um,
probably the best tip.
as much as people are gonna harp on like being prepared for the case, which is important, I think for me, the one thing I would say is like not to make the stupid mistakes as a med student. So try not to touch the scrub text table unless, of course, you know, she's okay with it. Be nice to the circulator, pull your gown and gloves, like the little things where you're not like control what you can control, more or less. Like you can't control those things. You can control not getting in the way. You can control not leaving the room with everyone being like, all right, can we get this student out? Or they're messing up the case. And no matter what you do, try not to break the sterile field. It's hard coming back from that.
I'll just chime in real quick. I think having a can-do attitude and a positive mentality, I think that kind of is like contagious and spreads in the room, especially when there's a tough day ahead or a long day ahead. I think just being someone that when you're in the room, people can appreciate that you're in a very, positive attitude. You're willing to do whatever it takes. I think that goes a long way, and it's a little bit more than just always being prepared for cases. It's a little added like personality thing that we tend to look for in people.
For me, it's sorry, working hard and doing so humbly. I think medical students forget that we were medical students very recently, so we get it. We see the game, and you don't need to help us see how hard you're working. I mean, sometimes it can be a little bit like, oh, look at me, look what I'm doing. Like, I don't want to see that. Like, just keep working hard, and it will be noticed. As much as you might think that we're too busy to notice what you're doing, we're not. Like, we see it, we're evaluating you.
Yeah, I guess on the last one, just an additional thing, just be yourself and don't overthink it. Don't try to be someone you're not. Don't try to act the way that you would normally act. So if you have common sense and you don't overthink it and you approach it, with a smile on your face, you'll be in good shape.
Thank you, everyone. As we draw to a close, we want to extend a heartfelt thank you to our awesome panelists for sharing their insights and expertise. Your contributions enriched our discussions and provided awesome tips and tricks for everyone participating on this call. So we thank you again. And now we'll pass the reins back to